All right. Okay. Hello, everybody. So we're gonna go ahead and do chapter 41, our peptic ulcer drugs. Please don't mind the kind of different looking screen. Just heads up on that. Might be a little bit of shakiness. We're not in the same room as we usually are, but just bear with us. We're doing what we can. Um, so let's get right to it, right? So, pretty simple. We got our digestive system. This is pretty much relating anything regarding the GI tract, mainly with our main organs. We're kind of be more talking about that. But later in the next chapter, we'll talk about big things like the pancreas. So, the main portion right now that we need to really watch out with is everything regarding anything within the stomach and a little bit of the small intestine, specifically in the duodenum. This will play a big part in peptic ulcer disease. And then also for anything regarding GERD is obviously right here with our esophagus. And then anything for peptic ulcers can be two of different things, right? They could be a gastric ulcer, which is going to be in our stomach. And then they could be a duodenal ulcer, which could be kind of found a little bit right here, right after the stomach, once after food kind of exits. So we're just going to go a little bit down. Obviously, we have two different sphincters, right? We have our esophageal sphincter right here, which is, I'm pretty sure you guys might know, it's right about here. We also have our pyloric sphincter. Now, that sphincter is what separates, imagine this over here, as the stomach, and over here as a duodenum, so it holds everything against. So it's basically just like a kind of a door, same thing. So we'll get into it a little bit more when we touch on drugs that help with that when the sphincter is not working that well. But biggest things, right? These are going to play very big. The chief cells, right? They secrete enzymes that help out with creating gastric juice, and parietal cells make hydrochloric acid. So when you bring chief cells and the parietal cells, right? So hydrochloric acid enzymes, which is pepsinogen, so pepsinogen is made by the enzymes. Hydrochloric acid is, well, I mean, it's its own thing. It's just hydrochloric acid. When you bring in an enzyme and you bring in hydrochloric acid and put them together, that makes pepsin. So that is our acid. That's basically just stomach acid. Um, just gonna go back down, and then we don't really need to go touch on this too much. Um, So peptic ulcer disease, right? A lot of different causes. The book made a huge emphasis on things like NSAIDs, and it made a big emphasis on H. pylori. The other ones that kind of did come up were things like foods, like our caffeine. Smoking was also another one. Didn't really, like beyond our studying, didn't really touch a lot on Group O, on the Group O type blood, but you can still kind of consider that one. But the big ones were NSAIDs, H. pylori, stress was mentioned, and caffeine and smoking, but the others were not that much. And these are kind of straightforward, right? Like stress, you're feeling stressed, you're gonna have increased acid buildup. Smoking tobacco, that's just all bad stuff that you're getting in, and that's going to be triggering certain receptors that we'll get into in a little bit. That will make more acid because you're bringing in like toxins into your body, so it makes more acid. So like try to break that down, but obviously that's not a good thing because now you're creating an ulcer. Another thing too, right? H. pylori, it actually thrives in a acidic environment, as we remember from microbiome. And if you guys recall, this is kind of more of a review from basically our first exam, if you think about it, right? Corticosteroids and NSAIDs, those were very big on causing peptic ulcers. So that's a little bit more of a refresher. But remember, the big ones, NSAIDs, H. pylori. Those are the ones you really have to watch out with. Everything else in addition, you do pay attention to, but those at least don't forget those two, because there's a lot of factors to remember, but at bare minimum, please remember those, right? Um, right, we're getting a little bit more into H. pylori. H. pylori, it's a gram-negative bacteria. In the end, we don't really need to know that much. We just need to know that H. pylori will cause problems, right? And that's what we really truly care about. Beyond that, right, there are additional causes, not just the NSAIDs and everything, right? Here's NSAIDs again. But another one that is in addition is hyposecretion of adequate mucus. So our stomach, right? It contains a big amount of acid, right? Like it's basically a vat of acid. And that acid is pretty corrosive because the pH of that acid is like between 1 to 4 typically. Obviously, we need some kind of protector, right? So imagine this is like the wall of the stomach, and then it burns up a lot because there's so much acid in here. You need some kind of like a thick paste of a mucus. That mucus prevents the acid from corrosion. The big thing with H. pylori is that H. pylori actually breaks down that mucus and creates a little gap within the stomach lining. Once it figures its way in there, it's just leaving that gap and it's starting to allow all that acid to start burning into the stomach and creating the ulcer that we're talking about. Again, if you're taking NSAIDs, if you're smoking, if you're having high amounts of stress, which produces more acid, that's just going to make it worse. So it's almost like a like double trouble if you think about it, right? Because H. pylori kind of produces our body to make more acid, and then it's also lowering the mucus production, right? So we're losing our protective barrier and we're also creating more of something that's kind of hurting us. So those, in addition to the ones mentioned on the slide above that we just passed, um, remember hyposecretion of our protective barrier, which is that mucus that we need, right? Because it's just like a thick sludge. That's basically going to cause problems in making an ulcer. Now, people that you do have to watch out a little bit more that don't make that much mucus could be people who are older. Older people, the body's slowing down. It's not really working as it once was. Peristalsis is also going to be slowing down, right? That's very common with older people. They get they get constipated very often, which again we're going to touch on that later. But older age can cause a hyposecretion of the mucus. So again, remember these different factors and just add hyposecretion of that protective barrier in this to the ones I mentioned above. These are just a review. H. pylori was mentioned again, but remember, if we see things over and over, that typically means that it's probably really important, right? So now we're breaking it up from PUD, right? Imagine this is an umbrella. And peptic ulcer disease is just an umbrella term, and it can mean two different things. It can mean gastric ulcers, again, an ulcer in the stomach, or it can mean a duodenal ulcer, an ulcer in the duodenum. We went through the anatomy so you could kind of picture in your head where it is. Now, there are some very big things that go with the stomach ulcers, right? So, again, it's a hole in your stomach, right? That means that hole is basically kind of there for pretty much a good amount of time, right? And it's pretty much exposed all the time, right? Like when we eat, right? We eat food, it stays in the stomach churns it, it breaks it down, it helps break down proteins. It's like, it's like a washing machine and it's just breaking it down. But when we eat, does our food always remain in the stomach? It doesn't, because most of our absorption is actually occurring in the small intestine. So it could be possible that pain that is associated with the gastric ulcer could go away for the moment when you're eating, because like imagine again, you have your stomach in here. Like imagine this is your stomach, right? You have an ulcer right here, but now you're putting in food and that kind of like buffs out all that acid for the moment. But the moment all that food stays in and then eventually goes out into the duodenum, that area is just exposed now. It's just back to normal. There's nothing else. The acid is back at full function and it's just burning back up. That's why when people have gastric ulcers, yeah, pain can go away when they eat, but eventually it's going to come back. Typically the pain just comes back after eating as well. So it's kind of always hurting. That's the problem. It's always an issue. So again, if the problem is that it you get pain when you eat, would you really want to eat? Probably not. That's why patients would be anorexic. And obviously, that doesn't mean they're skin and bones. Anorexia just means that you lose your appetite. Because if pain is always associated with food, you're not going to want to eat. It's just going to cause it to get worse. Like sometimes, like you get a pause of pain and then it goes away, or that pause goes away and then it comes back even stronger. That's probably what's occurring. That's why people are not wanting to eat. Obviously, once you get anorexic and you don't want to eat, weight loss can start coming in, right? And then vomiting, of course, because vomiting always happens with damn near everything. You probably scrape your knee and you vomit. So Remissions, right? Remission just basically means it's in pause. Like it's you're not really feeling pain anymore, but it could be there. It's just it's kind of hibernating, right? It's always infrequent, right? Sometimes it goes away, it comes back. Gastric ulcers are a big problem, um, and a big thing too, right? They're associated with cancer. Now let's imagine this too, right? The stomach is a an organ that is constantly exposed by a caustic chemical, which is that the our pepsin, right? The stomach acid. Um, and someone fact check me real quick that I'm saying pepsin is the acid, not Pepsid, because Pepsid is a drug, right? Okay, I just want to make sure that I'm not saying something wrong. But right, so the stomach is constantly exposed to this caustic chemical, basically our acid, right? When the body is constantly damaged over and over, our body obviously has to compensate by creating more cells. As you create more cells, more and more cells, especially when you have that ulcer that's just, you have no barrier, you have nothing covering it, and you're constantly hurting the stomach over and over and over, your body's making more and more cells. Eventually, there is a problem that could occur in the mitosis of creating more cells to help like heal what's going on. And that's why cancer is a very big thing, because you need to watch out with that, right? Because like again, it's exposed skin, it's, well, not skin, but it's tissue, right? And it's just over and over getting hurt. That's why, just remember this, because it's a big thing, right? Gastric stomach cancer, again, all cancers are bad, but I always want to watch out with that one. Yeah. um, so we can now start going down, right? Oh, another big thing before I forget, right? Common signs and symptoms of people having gastric ulcers, they kind of vary, right? If the ulcer is fresh and it's ongoing with bleeding, patients can start vomiting bright red blood. If the ulcer has been going on for a good amount of time, like it's been chronic and it's not really bleeding all the time actively, they could vomit coffee ground emesis, which is basically just like a tarry looking blood, like just vomit. It's black. It smells bad. So again, because that's just basically blood that's just been destroyed by the hydrochloric acid in the stomach, right? So that's very big to know when it comes to a gastric ulcer. So if like a question comes up about, oh, your patient has vomited or reported vomiting of bright red blood or vomiting this coffee ground looking substance, chances are it would be a gastric ulcer. And it makes sense, right? Because if they're doing that, it's probably, if they're vomiting something out instead of pooping it out, chances are, like, we look at the stomach as like kind of the line of, the where you can't cross it anymore, right? The minute you pass it, you can't go back. So if they're vomiting, chances are it's the stomach. If they're pooping out blood, which will come up right now, that chances are it would be, and then we're going to transition to a duodenal ulcer, right? So we went through the anatomy real quick, right? And just kind of like a quick little review, right? Duodenal ulcers. That's basically going a little past. So to give us a little review, esophageal sphincter, stomach, pyloric sphincter, duodenum, right? Now you kind of know where the flow is coming from. So as we go down and get back to this page right here, right? So for gastric ulcers, we were talking about how pain is constant when you're eating, right? Like it's still going to occur when you're eating in gastric ulcers. It can happen right after. Pain doesn't really get relieved. Well, in this case, it's the opposite for someone having a duodenal ulcer, right? Because now that is in the small intestine. The duodenum is part of three other different. The small intestine is the duodenum, the jejunum, and the ileum, right? So those are all just one big part of the small intestine. And what did we just review a little bit ago? When we eat, right, the stomach, the food is only at the stomach for a little bit of time, and then by then, most of the time it's spent in the small intestine because we want to absorb all our food, right? So if you have food in the small intestine, which is where the duodenum is, your pain can actually go away this time properly because you have something there to kind of buff out what's going on, or like kind of plug up the hole. I mean, that's probably not what's going on, but you could kind of look at it that way, because if you plug it up, the pain can go away, right? So a lot of patients, unfortunately, can go into having. Sorry, I had the wrong slide. A lot of patients can actually find a lot of relief with eating a lot now. because they're always eating just to keep the pain away, right? In terms of this, a big thing that they say for the symptoms is gnawing. That actually comes up a lot. Gnawing or burning. The burning makes sense because it's a gastric ulcer, or I'm sorry, it's a duodenal ulcer. All ulcers are basically going to be burning pain, but a lot of questions that we have run across, a good handful of them actually mention this gnawing pain. So try to make that connection of gnawing with duodenal, right? Because that is a very big thing for this type of ulcer, right? All ulcers in the end will have burning pain, but for some reason, gnawing pain is going to be something titular for duodenal ulcers. Duodenal ulcers are a little bit more common than gastric ulcers, funny enough. I mean, in the end, most of our ulcers are actually caused mainly by H. pylori. And I mean, H. pylori can kind of be anywhere, but it really likes the stomach. But in the end, this one is much more common, which kind of makes sense. I mean, sometimes a lot of people eat like foods that kind of cause them to have a little bit more acid production. Uh, Beyond that, right? A lot of pain at night. Why would that be, right? The stomach is empty. Again, that could also mean people could be eating a lot more at night to kind of keep that, the weight away. Weight gain could occur, right? Because again, you're eating more in order to keep the pain away in a duodenal ulcer, right? So another thing, like I said, on the other slide, right, with gastric ulcers, bleeding may occur, but this time you're not going to be vomiting it. You're going to be defecating it. And that's where you get those dark stools, the coffee ground looking stools that obviously patient can report smell terrible because they are. It's just blood that's been destroyed and like it smells terrible. So to review, big points: gastric ulcer, still pain after eating, bright red vomiting or coffee ground vomiting. A lot more coffee ground vomiting than bright red, but both are possible. And then for duodenal, again, pain goes away after eating. Gnawing pain is a very big name with it. And then a lot of nocturnal pain. Nausea and vomiting will occur the same way. I mean, you're in pain. I don't know anyone that hasn't been in a lot of pain and not vomited. Or and then bleeding again, but this one is more related to bowel movements. So now we're moving down, right? We're now going to be talking about the treatment of peptic ulcer disease, right? So obviously the main thing, right, is if the person has H. pylori, the most important thing is first test for H. pylori. That's like the pivotal. I think anyone that's having any type of gastric issues or whatever, that's like the first test they start giving, because if they start giving you treatment for the ulcers, in the end, it's only going to do so much because you need to kill the bacteria as well, right? But so that's a test that like almost we can even see in the test question. Like patient comes in, what test can you expect for them to have? Like for sure, other than the routine labs that you always get, chances are they're going to have an H. pylori test because that is very, very important. Because without those antibiotics, and to review which antibiotics would we use, we would typically use things like I'm going to zoom in a little bit so you guys can see a little better. We would typically use drugs like a little higher. Okay. We would typically use drugs like clarithromycin. Well, I mean, the ones that we actually went through, metronidazole and tetracyclines, and along with that, vancomycin could be used as well. It's possible. Because again, they're very strong antibiotics. So online, I did get a very nice acronym that was given from the lady at Registered Nurse RN, and she gave this nice like setup for us to know all the drugs that are typically given for any type of ailments regarding peptic ulcers, right? So it's antacid medications help basic peptic ailments. Antacid meaning antacids, medications standing for mucosal healing, or sucralfate, which we'll get into in a little bit. Help are our H2 receptor antagonists. Basic are our bismuth, which is basically a fancy way of saying Pepto Bismol. Peptic are our proton pump inhibitors, and ailments stand for antibiotics for H. pylori. I did add this little asterisk and color code for us to know that these last four are all given in combination typically for H. pylori infections. Obviously, the most important one, antibiotic. But the other ones that are going to help out to reduce pain, make the environment better to kill that H. pylori would be the PPIs and the H2 receptor antagonists. And funny enough, Pepto Bismol actually can help kill H. pylori. Obviously, it can't take all the weight, but it is a very helpful tool in that. Try to remember this acronym because it really helps out. Antacids and the mucosal healings, those are more supplemental, but the most important ones are these last four that you see right here, right? And funny enough, the slide does go into it and it mentions it here, but I kind of really liked that acronym that was given by the lady from Registered Nurse RN. She made such a good explanation regarding that. So I'll share that video as well because it's kind of a long lecture, but it's a helpful lecture because it lets you understand what's going on. So we'll go ahead and move on. And again, here it is. I mean, treatment for H. pylori. This is just going to be, goals of treatment. Make sure the bacteria is gone. Obviously, you want to first make sure the bacteria is actually there, and then start giving the antibiotics, and then give those PPIs, those H2 receptor antagonists, and the Pepto Bismol. Right? Again, like we've learned, right? Like what happens with most bacterial infections if you don't fully kill it? It's just going to come back, and it's going to get resistant. Now, God forbid H. pylori gets resistant to antibiotics. At that point, I don't know what will happen. But long story short, right? This can be lifelong. I mean, this bacteria has proven to be very just, well, not toxic, just very I guess you could say annoying. Like it's just, it has a very strong will and will stay alive, right? So this is just another slide regarding that. Look, there it is, bismuth compounds, which is another fancy name again for Pepto Bismol. And then the proton pump inhibitor, again, we mentioned that above in the upper slides. I guess just more watch out with PPIs because that was mentioned directly from the professor. Again, as always, whenever we find online resources, it's not always going to be what they say, but it's more just what's going on. But at bare minimum, please remember you're going to be using Pepto Bismol, you're going to be using proton pump inhibitors, and obviously, most importantly, you're going to be using your antibiotics, either our vancomycin or our metronidazole, right? Remember at least those because those are the big ones. Moving down, right? So now we're talking about GERD. So GERD, again, everything regarding the esophagus. We want to watch out with that. So the hugest thing about this one, it's not always like that, but typically this type of disease is related to the weakening of the esophageal sphincter, right? So the sphincter is that muscle that basically like keeps everything closed. Again, it's preventing things. Here's the stomach, here is the esophageal sphincter, and then here is the esophagus, right? So we want this constantly contracted because if not, you're going to have GERD, and then you have those, that acid reflux that you're getting. Now that acid reflux can end up causing issues, right? So you want to prevent that. But the biggest thing is that it's associated typically with obesity. That's just unfortunately something that happens. And I mean, it also goes to show like certain things that you would do, like what would you do for a patient that has GERD? How would you lay them in bed? You would you would probably put them at bare minimum like a low Fowler's, but you would not want to put them supine, and for sure you wouldn't want to put them Trendelenburg because at that point you're kind of just like suffocating them in their own acid if you think about it. I mean, that's extreme, but it could happen, I guess. So first and foremost, the most important thing that you can treat GERD with, and hilariously enough, it's actually the most common thing that anybody really can kind of get, like especially for your type 2 diabetics, is lifestyle change. If this is constantly associated with obesity, if you help reduce the obesity, it's very likely that you can treat this. Now, obviously, if that doesn't work, you're going to have to end up using drugs that are going to have to involve themselves into that. So the main thing with treatment, right? The biggest thing, you want to reduce the gastric secretion. So there are typically a lot of drugs that can go with this, right? The big ones are going to be the PPIs and the H2 receptor blockers, right? And right here we put proton pump inhibitors and with Prazole. H2 receptor blockers and with Tadine. Antacids don't really 100% help. They're like a band-aid. It's like putting a band-aid over a massive bleed. It's not really going to do a lot, but it can help for the moment, but it's not ideal, and they don't last that long. These PPIs and these H2 receptor blockers, they last long. So if you lower the stomach production, the acid production in the stomach, you can help out with GERD. But obviously, the biggest thing you want to do perhaps is just get the patient to change lifestyle before you start actually giving them drugs that can start having some side effects, right? Surgery is possible, like always. I mean, if it's a muscle problem, chances are you could have surgery. Again, it's not ideal, but it's likely. I mean, after all, it's something that's direct about muscle, so you could always kind of help tighten the muscle with surgery. Now we're starting to actually get into these types of drugs, right? So our PPIs. The biggest thing that I want to let people know is that PPIs are actually activated by food, right? So you need to take it before you eat, right? Have it in the stomach, ready to go. It's in your stomach. Food comes in, now it starts activating and it starts working. The last thing you want to do is put food in the stomach first, then take the med, and now you got to kind of wait until like it start, because usually these drugs are enteric coated, so that you know what that means. No crushing. You do not crush it, and now you have to wait even longer. And then what if the food passes out, and then now the stomach, like the PPI is left in the stomach, it just missed its window. So the first thing you do with these PPIs, you eat it, you take food before eating. You always prior to eating. Again, I underlined that they end with Prazoles, a lot of Prazoles. And a big example that we used was I like what Jonathan did, right? Apparently the guy that voiced Tow Mater, he was very big on, like, I guess he became the spokesperson of omeprazole, and the trade name for that is Prilosec, right? So in the grid we made by Victoria, Bernice, and Paris, um, thankfully we have these very helpful photos that help, and we put a little Tow Mater because this one we want to remember that omeprazole, the Prilosec. And to make it catchier, watch the commercial. It's just going to help you remember it. I mean, yeah, so you're just going to picture like Mater saying that, and then like immediately that's going to remember that. Now, we'll start touching on like extra things about why like he looks disgusted at that black whatever the heck that is. That's probably an oil spill. So that's we'll talk about that in a little bit. So right, proton pump inhibitors, right? These basically shut down the stomach in a way if you kind of look at it, because these protons, what they are is legit the byproduct of acid. They're like, they could be H electrolytes or potassium electrolytes, and those are acidic in our body, if you guys remember from physio. So these cells specifically, um, they are called H plus K plus ATP, like ACE. It's a weird name, but it's, long story short, hydrogen, potassium, adenosine triphosphate, ACE. Like, it makes acid. That's, as fancy as it sounds, it just makes acid. So if you take something that prevents these protons from pumping out acid, right, a proton pump inhibitor, you're basically turning these cells off. These cells are directly responsible for creating acid in the stomach. So this one can actually really stop production of acid, which can help out with, again, you're helping out with all those, the peptic ulcers, like your stomach acid mainly, the big one, gastric ulcers. Um, Typically, it takes 4 to 8 weeks. It could take up to 2 weeks to really start like giving the full effect of like, oh, I'm starting to feel better. But typically these drugs are given, they're short-term drugs, 4 to 8 weeks. A lot in the books mentioned 4, but it could span to 8 weeks. It just depends on what it is, right? 4 for peptic ulcers. It could be 8 for GERD, because GERD proves itself to be kind of a problem. It seems like it's a little difficult to treat, again, because it's more of a muscle issue than like like a chemical issue, and always like muscle issues, neural issues. Those are always a problem to fix. So it could take longer, but typically it's that 4 week stuff for the ulcers. So try to recall that. I mean, it's the same thing with the other drug we're going to talk about. So typically it's that 4 week window. Big things with that adverse effects, right? So now we're going back into the picture of Mater. So what I like to picture in my head is that like Mater woke up in the morning, right? Because you have to wake up in the morning and take this drug before you eat breakfast. So that's already one way I start remembering this drug. Mater woke up in the morning. He's like, oh man, we're gonna go do stuff with Lightning McQueen, right? But I gotta eat breakfast first. So he took his medicine like how he's supposed to before breakfast, and now he rushed to go get breakfast. But in the time that he was going to go get breakfast, he actually hit his head. So the whole reason why I'm getting all convoluted with it is because this can cause a headache, right? So Mater ran, or drove, I guess, if you want to call it that, and he hit his head, and now he's nauseous. And then, funny enough, he also had to go to the restroom, so he ended up having diarrhea, and that's why we have that oil slick right there, because that's nasty. Um, so that's one way to for us to remember him. Like we'll just again another thing too, right? Mater, he's all rusty. We could look the rust as a rash, and then abdominal pain. I mean, that one's kind of always. Yeah, we could say that he's gassy. He's bloated, so he's gonna be all like painful. But big thing, I mean, after all, these drugs they mess with the stomach. You're gonna end up having some kind of stomach pain. Like that's just what's gonna happen. Um, Big thing with this one, right? Long-term use is associated with gastric cancer. So we talked about how peptic ulcers themselves can cause gastric cancer. But the biggest thing with this is that we need to watch out because, again, you're turning off the cells in the stomach. Think about that a little bit, right? Our body is not really supposed to be doing that. That's not normal. If you turn off those cells, your body's going to think something's wrong. They're going to start creating more cells. And again, it's a cycle that repeats over. You're making more and more cells over and over. Your body's like, hey, we got to up production. What happens when you create too much production with low quality assurance? There's going to be errors. Those errors could end up being cancerous tumors. And then those tumors eventually can lead to the cancer. So that is why you don't really want to use this long term. None of these drugs are really supposed to be long term because, again, you're throwing off the normal physiology in your body. So you only want to be taking these as recommended, as mentioned, for that 4 to 8 week window. Sometimes it could stretch to 12, but that's very rare. It's more about that 4 to 8 week window. Always make sure to mention that because that's very big. Um, Big thing with the other names, right? Pantoprazole. For me, I don't know. I just think of pants. And then another thing too is like the brand name actually has Protonix. It's the only one that has a T in the name, like Panto, Proton. I mean, it makes sense too because proton, right? Proton pump inhibitor. But at least this one has a T. So if you see Pantoprazole, that T is what helps me remember. Oh, Protonix. But the big one, I really like Jonathan's example of the omeprazole with the Prilosec because I mean, come on, it's Mater, it's freaking Cars. That's a good movie. So we're gonna go into a little bit more in depth, just certain things that I highlighted into the indications regarding omeprazole, which is our prototype drug, right? So the big thing is right, short-term treatment, big thing. 4 to 8 weeks, as we already mentioned before. The effects could last up to 72 hours. I mean, makes sense, right? It's an inhibitor. Usually these drugs are pretty strong and they're going to be on for a little while. High doses, right? These high doses, typically they're not really going to be given for your average person, but there is this specific disease called Zollinger-Ellison syndrome. That is when your stomach makes a lot of acid for no reason, really. Like it's just doing it because it's doing it. And unfortunately, that just people have to typically use high dosages to turn it off because it's regarding tumors, I guess, in that way. So the big thing, if you're having tumors that are making too much acid, you need to take high dosages because those tumors are working too well, and then eventually you have to take it for longer times. This is not usual. This is why it's red. It's not for everybody.
Sorry, so it can lead to that or it can help treat that.
It treats this.
Okay.
It basically treats Zollinger-Ellison, which is a type of tumor kind of like thing going on, which again, tumors in the stomach. These are tumors relating, because after all, it's the stomach lining, right? So you're going to be causing all this type of stuff. Hmm. Yeah, so yeah, pretty much tumors. It's just that's the name for it. Tumors in the stomach, but it's it's not always straight up 100% like the whole cancer thing, but it's your tumors. So Zollinger-Ellison syndrome, that is where tumors come with, and then obviously, I mean, after all, what like tumors in other areas create too much product of something. That happens before too. So that's why. So typically, omeprazole, the only time it could be used chronically, because again, at this point, they're already happening, so it's might as well just try to attack it. It's when you have Zollinger-Ellison. Um, Big thing, right? It can be used for children ages 2 and older, but it is not in terms of over-the-counter medication. It has to be prescribed typically. These drugs aren't really meant to be used by kids. They could be, but they're more of a prescribed drug than they are a, hey, over the counter, here, take them. They they should not really be getting these. Um, an additional thing to watch out with is that there is a combination drug called Zegrid, which is omeprazole mixed with sodium bicarb. So it's basically a proton pump inhibitor with an antacid. That's pretty much what it is. And it's the antacid is more that supplemental to provide immediate relief. Um, the PPIs, the H2 receptor blockers, those take a little bit of time to make an effect, while the antacids are an immediate effect. So that's why Zegrid is like, again, it's like best of both worlds. If a patient's having too much acid in the stomach and they're having a lot of pain, they could take Zegrid. The sodium bicarb increases the pH in the stomach, relieving that pain, and then the omeprazole starts doing what we mentioned already. Again, here it is again. Administer before breakfast. Again, Mater woke up, took his pill like he's supposed to before breakfast, and ran to go get food, but he hit his head, and then he freaking was unable to hold it, so he diarrheaed all over the floor. Yeah, so that's nasty. Uh, Biggest thing too, this drug, as we already saw with Zegrid, can be given with antacids. This is going to be very different when we talk about the next drug. So watch out with that because it's the only one that can actually be used with antacids. Um, Beyond that, again, a lot of these drugs, they're enteric coated, they're for long duration use. You should not chew them. You should not alter them. You should not do anything. Just swallow them only. Category C drug, just to throw that out there, you know. So it probably should not be used by a pregnant woman, probably, unless it's that necessary. Again, so what I squared here in blue, those are already brought up. Like we already mentioned those, so we don't have to talk about it that much anymore. But another one that we could talk about is blood disorders, right? So think about this. Our stomach normally is used to help break things down and help absorb food, right? And what we use to do that is the stomach acid that we have. That's the most important thing because it's breaking down proteins, it's churning, whatever food we have and turning it into chyme and then putting it in the stomach or the small intestine, right? So if we are lacking a piece of the puzzle, right? So the stomach's still churning the food, but the stomach is not making that acid that we need to break down the food, then food is not going to be able to be absorbed anymore. That plays a major part when you're now not absorbing calcium anymore, you're not absorbing magnesium, you're not absorbing vitamins like your B complex vitamins. And that we learned in our vitamins chapter that B complex vitamins have a lot to do with blood production. We also have a lowered amount of absorption for iron. All of those vitamins that we just spoke about, they have a big part in blood production and other functions, right? So if you don't have your acid, you're not absorbing those very important electrolytes or vitamins and minerals, and eventually you start having blood disorders because of that. It's possible you could become anemic because now intrinsic factor, after all, is secreted by the stomach. If you are not making any of your secretions that you're supposed to be in the stomach, because for sure it's going to shoot blindly and it's just going to affect whatever it finds, and that's referring to the drugs, then you're not absorbing any kinds of vitamins properly. So eventually, blood disorders come in, CBC counts can start going down. Osteoporosis can actually start occurring because you're not absorbing calcium anymore, and fractures could occur in long term cases. Again, there it is the hypomagnesemia. You're not absorbing magnesium anymore because that stomach acid is what helped us absorb it. Um, Again, atropic gastritis, you shut down the stomach for so much that it doesn't know what to do anymore. You've basically turned it off because it's like what we're going to talk about with the laxative drugs with older people. You basically just turned off that entire system. Something's wrong and the stomach knows it, so it starts flaring up like crazy, but in the end there's an issue and it's not going to be able to fix it, right? That's why it's just overall talking about everything mentioned here. In addition, remember, our stomach acid, our entire body is of normal physiology, constant steady state. That is what our body is always striving to do. These drugs are altering our steady state. And the moment we do that, that stomach acid not only helps us absorb all these different things, process all this food, helps us break down all this and that, and helps us absorb medicine as well, but it's also helping fight foreign invaders. The minute you get rid of that acidic environment and you turn it alkaline, now you're inviting foreign pathogens to basically come in. They're like, oh, well, the stomach that was holding us back, the acid in there, that was holding us back. But now we could bring in C. diff. And then in conjunction with that too, with the lowered CBC count that can happen and also the low amount of stomach acid, now we have pneumonia that could occur. This happens a lot with those drugs that directly affect the stomach acid production. So that is our PPIs, and we're slowly going to get into our H2 receptor blockers, but we still got a little bit to go for the PPIs. But we just touched on all this. I hope now that helps us understand why are these different things happening, because there's so many different factors. The stomach acid helps defend the body from C. diff and pneumonia, those bad pathogens. They help absorb things. Calcium, magnesium, iron, B complex vitamins, which if you don't take those, they bring it down. Now, going on to drug interactions, right? A lot of things that go on with this, right? Biggest one with this, warfarin. I mean, this drug is always reoccurring with so many other medications, but use with omeprazole and a lot of prazoles with warfarin, like always, increase the chances of bleeding. That always happens, right? PPIs could increase the gastric pH, right? So that just means it's becoming more alkaline. And again, it messes with absorption of a lot of acidic drugs like ampicillin, a couple of these antivirals, digoxin, iron salts, azole antifungals, right? Again, our stomach is normally acidic. That is very important for any type of medication. Like a lot of medicines require that acid. So if you get rid of it, can't really absorb those medicines anymore and they won't work. So the big ones are these are acid-based chemicals or medicines that require that environment. If you don't have it, then you're not these aren't going to really work that well. It basically kind of turns them off. Um, Other of these drugs, right? Like CNS depressants, diazepam, a lot of CNS depressants, right? They're basically shutting your liver down because your whole body is basically shutting down, right? And like not really that it's shutting down and causing liver failure, but your whole body is turned off a little bit, right? CNS depressants. After all, that's what's creating and helping move everything. So if your liver's not working, you're not really metabolizing this drug, and the drug can actually stay in the system for longer, giving like a much more extended stay of the drug. Um, and then there's these other drugs, these antivirals. Again, they could just lower the levels of the omeprazole, lowers levels of antivirals, which we already talked about over here. Again, a lot of these drugs lower, you increase the pH, you're not going to absorb a lot of medicine anymore. Lab tests, right? ALT, AST, surprise, surprise. These are what a lot of drugs do. Um, Ginkgo and St. John's wort, they lower the levels of omeprazole or lansoprazole, so you got to watch out with that. I mean, usually ginkgo and St. John's wort actually increase a lot of levels of things, but funny enough, these actually calm it. So kind of an opposite effect. I guess you could kind of perhaps make some kind of connection, but in the end, just kind of know, or if a kind of question shows up, just think of the most generic ones because we hear ginkgo and St. John's wort a lot, and just what could occur with it. Just they lower the level of the prazoles, omeprazole. Um, Biggest thing with this, role of the nurse, right? What do? We do the liver function and all that stuff all the time. You're supposed to do that. Smoking history, that's just putting them for risk factors. Take 30 minutes prior to eating, usually breakfast. Again, you're supposed to take these at breakfast, and then, or take these before breakfast to make it clearer, and then they could be administered with antacids. That's pretty much it. There's nothing else to really go about it. Now we're going to get into our H2 receptor blockers, right? All right. Now moving on, we have our H2 receptor blockers. So funny enough, Jonathan was saying something that actually is pretty interesting. It seems like these drugs, right, PPIs and H2 receptor blockers, even though they have the same goal of basically slowing or shutting off production of stomach acid in, well, the stomach, these are kind of opposites in some ways. Like in this case, H2 receptor blockers, they don't exactly 100% stop the production. Um, Picture the receptors as like the phone that calls those proton pumps or cells or whatever you want to call them, and tells them to make acid. So if the phone is basically gone, right, you can't get a hold of them. The stomach can still make it, but they just don't know when. There's just, it'll make them in some cases or not. And with these H2 receptor blockers, it's like you're slowing it, but you're stopping it at the same time, while PPIs are more about stopping it completely. That's why, again, there's a lot of risk of gastric cancer with PPIs compared to these. Um, so, again, they treat peptic ulcer disease, as mentioned, with PPIs, but they're a little different when we start getting into the specifics. So, these drugs, they all end with tadine. We got rantadine. We came up with Zanran because Zantac is the brand name of rantadine. Zacran. There's also famotidine, which is Pepcid. We thought of a peppy family, like a happy family, right? There's that. Um, Adverse effects that typically happen. Funny enough, look at this possible reduction of red blood cells and platelets. Where did we hear that before? That was heard in the PPIs, exactly. But funny enough, this one actually causes impotence in men. So when we drew the photo up, right, we have a little family here, and the whole family looks happy, but the dad doesn't look happy. so so we did that like in that way, just to like help remember, famotidine, family, peppy, family, Pepsid. Um, um, it was a really good idea. Okay, so so to get in the specifics of rantadine, to give a little bit of like a kind of little tiny history lesson. The first kind of this type of drug that ends with tadine is called cimetidine, right? That drug was really good at its job. So good that it caused issues with your central nervous system. So that's like a first generation drug. That drug is not really used that much anymore, right? And we saw that a lot with like our antibiotics. So older they are, the more problems they cause. So obviously science innovates and it makes better drugs. In this case, now rantadine is the one that takes its place because they actually don't cause as many symptoms as cimetidine. Not to say it isn't, because again, it's a byproduct. It's still part of the family, but it has a lower tendency of causing central nervous system issues. So it's kind of interesting how that happens, right? Again, there's that 4 to 8 week window. Same thing as always. We saw that with the PPIs. Um, it's given to those that are high at risk for it, or those with high risk for PUD. Those can get a little bit longer use. We saw that again with the Zollinger Ellison syndrome, right? They can take higher doses and they can take it for longer, but that's only in special cases. The same way how people who are at risk of peptic ulcer disease can take these drugs for longer. And I don't know about higher doses, but they still can take it for longer. So special situations can call for special times when you could take a little bit more, right? Um, in the end, gastric ulcers, they're the prime thing, right? They're the thing that's making the acid first and foremost. So those can take longer, and it makes sense, right? Because in the end, it's right where everything's made. It's the epicenter. Um, Typically, these can be given IV or IM to treat that acute, like bleeding ulcers. Those like brand new, they're like vomiting blood, like actual red blood. They can be given IM or IV. Other than that, typically it's PO meds, but those are your special circumstances. So um, there is a combination drug. There is a Tritec, which is rantidine, with bismuth citrate. Now we said our bismuth. Uh, that's not exactly Pepto Bismol, but it's one of the families. Pepto Bismol is bismuth salicyclate. This is bismuth citrate, so it's not exactly the same thing, but it's under the same family. Um, it can treat children with GERD, and it can treat infants as well, but they have to be older than a month. Again, same thing. These drugs can be used by children, but it has to be prescribed. It is not for over the counter use, typically. Um, and then there it is, Zollinger Ellison syndrome and erosive esophagitis, which would be part of your GERD. So, long story short, it treats PUD, it treats Zollinger Ellison syndrome, it treats people who are at risk of PUD, and it's treatment of GERD. Um, Moving on, right? This one, in comparison to our PPIs that you take them before breakfast, you take H2 receptor blockers after eating, right? There's that weird like yin and yang. They're a little different, even though they do the same thing. PPIs were category C. H2 receptor blockers are category B. Kind of weird, right? Yin and yang. One's kind of safer, one's kind of more dangerous, right? I mean, after all, PPIs cause that cancer. They could cause cancer, so that's where that category C could play in. These not so much. That's why they could be category B. Um, Adverse effects, right? Headache is a new one, right? But we saw headache with PPIs, and we're kind of noticing a pattern there. Um, well, the things that are boxed already, we mentioned prior. There is it just funny enough, it does not cross that blood-brain barrier, right? So it doesn't cause those CNS depression or issues that you saw with cimetidine, what we mentioned earlier as the first of its kind of these types of drugs, these tadines, these H2 receptor blockers. Um, there's that impotence or loss of libido in men. So again, peppy family. There's that example. Um, just like we saw with our PPIs, it can cause diarrhea, which that's what PPIs do. Mater with the spill he had on the floor, if you guys remember that photo, and C. diff, right? And again, it's the same reason why PPIs can cause C. diff. You're changing the environment, you're increasing the pH, you're inviting all these different bacteria to come in and live there and thrive. Um, Lots of contraindications, right? Acute porphyria, or how the heck you say it, it's just a big problem that's going on in the body that's causing a lot of different effects. Rash is a very big kind of tell on this one. Not sure if it'll come up, but this one's kind of something to think about, I guess. Um, So, over the counter administration can be given to children that are 12 or older, but not 12 or younger, right? But that's weird because we just said that it can be given for up to infants 1 month or older. But again, it could be given prescribed by a doctor, not over the counter, because we've seen that people abuse or have the tendency to abuse over the counter drugs. So you're not supposed to do that, right? And I guess to give a little bit of a summary, right? We said that PPIs are a little bit more dangerous because they actually kind of somewhat short. They shut down the stomach. Those can't really be given to children under 18. It's really strong. It's a very effective drug. The stronger it is, the more likely it shouldn't really be for kids. 18 or younger should not be used unless prescribed by a doctor. That's in referring to the context of over the counter use. These H2 receptor blockers, these tidines, they end with tidine, right? Rantidine, they could be used over the counter, but they have to be 12 or older. That means it has a little bit more of a safety margin. After all, we saw it. It's a category B drug. It doesn't cause that many issues. So that's something to kind of know. There's a yin and yang to these types of drugs. Interactions, right? Antacids should not be given in this case. But wait, we give antacids with PPIs, while not with H2 receptors. They mess with their absorption. You should not be taking these with antacids. Um, Again, they're reducing absorption of these types of, look, these are all antibacterial, anti-infectives. We said that earlier. A lot of these anti-infectives rely on the stomach acid to break down and start working. If you get rid of that stomach acid and now you're bringing up the levels and making them more alkaline, they're not going to be absorbed. And then smoking overall just decreases the effectiveness, which makes sense because you're now just you're bringing in a caustic chemical and you're making the body get like thrown out of whack, and now your H2 receptors are now really working and now they're making more acid, so it's just basically canceling out. We saw this AST, ALT, LDH, alkaline phosphate, ALP, bilirubin, all have to do with liver. So we're noticing a pattern. These are all messing with the liver. um, Again, look, there it is. Absorption of B12 is, it depends on an acidic environment. So if you bring up your acid, or you're bringing up the pH, I'm sorry, and you're making the environment more alkaline, you're not going to absorb B12, so a deficiency can occur. Iron, again, we're noticing this from PPIs. It's the same effect. That's why you're also going to have issues with labs as well, because you're not absorbing what you need to create a proper blood production. I have to delete that. All right, we're good. Okay. Role of the nurse, right? So obviously, check patient how they use their over-the-counter meds. They should not be. If over-the-counter isn't fixing it, obviously they're going to need something different. That's kind of standard, right? Obviously, if the pain is constant, again, it's just showing. This is just really kind of obvious, these last three statements, but this is big, right? So we said cimetidine, right, or cimetidine, that was the original drug. It caused a lot of issues, as mentioned up here, right? There's a lot of CNS depression with cimetidine, that first generation drug, that early drug, right? So a lot of times when given by IV, it actually caused dysrhythmia and hypotension, which is again signs of like a CNS issue with cimetidine. So that's probably not a choice drug anymore when given IV or IM or any of that type of stuff. Now, thankfully, rantidine and famotidine, those Zacran and Pepi family, those actually can be given by IV because they don't cause those issues that cimetidine was doing, which is pretty nice now. It shows that they have a little bit more of a universal use, especially for those acute gastric ulcer like attacks where the patient's like vomiting blood. Obviously, you always want to check their kidney and liver function. That's always, and then the CBC because possible anemia. Because what did we say? You have a lowered absorption of B12, magnesium, iron, and calcium, which this one's still going to do. So you could still have those osteoporosis signs and symptoms. Now we're getting into antacids, right? Um, Again, full disclaimer, antacids are not really a solution to peptic ulcer disease. They are more of a here's a band-aid, right? That's all they are. They work fast, but just as fast as they work, they also go away. So they're not exactly a solution. Um, the biggest way that they work is because, right, antacid is basically alkaline. It's a alkaline substance. You drop it into the stomach, it raises a pH. It's a buffer. That's all it is. It has no influence on acid production or anything. You're just leveling out the acidity in the stomach. That's all you're doing. Um, there's a lot of these different drugs, right? There's aluminum hydroxide, there's sodium bicarbonate. A lot of these end with carbonate or hydroxide. There's magnesium hydroxide, which is milk of magnesia, but we're not going to be using that one in that example for an antacid. We're going to be using milk of magnesia for a different reason later down the line. Um, so we're mainly working with aluminum hydroxide and alternagel, right? So we kind of thought about, right, like aluminum, right? It's blue, like or the gel that we're thinking, right? Johnny B, that's a gel for that some dudes use, right? I use that gel. It's blue. So I think of, the guy that drank a lot of aluminum. If you guys remember, he looks like a Smurf. Well, he died actually recently. So, but he took a lot of aluminum. He drank a lot of liquid aluminum. I forgot what exactly it was, but he drank aluminum and his skin turned blue. So this is just a very long, dragged out way of remembering that aluminum hydroxide, the brand name is Alternagel, right? The Johnny B. Blue gel, right? The guy that drank aluminum. Bad connection, but it helps me. Um, Adverse effects typically constipation. That's really it. I mean, we mainly saw that these PPIs and these H2 receptor blockers they cause diarrhea. But these supplemental drugs like these antacids, they have a tendency to cause constipation. Um, the ones made out of magnesia and aluminum, they could cause, well, mainly it's the aluminum and the magnesia. Those can cause sometimes diarrhea, but sometimes it's constipation. It's weird. It's like a weird teeter totter. Some people can have constipation, others can be diarrhea. um, Calcium ones typically cause constipation. So antacids could be made out of calcium, they could be made out of aluminum, magnesium. Calcium has a very big tendency of causing constipation. Aluminum and magnesium, yeah, they could cause diarrhea, but sometimes it could also cause constipation. It's a little weird. The point is not made that well, but because the slide says constipation, just think constipation. So right now, at least, only put diarrhea in the head, which sounds weird, but put that only for PPIs and H2 receptor blockers, the ones that are directly affecting the production of acid. And because the slide right here says constipation, those helpful additional drugs, we'll just say constipation, just to give us like a line in the sand to know where to say like, oh, patient has an anti-PUD drug and they're constipated. Oh, they're probably taking a lot of antacids. Oh, patient is on a PUD drug, but they're having a lot of diarrhea. Oh, then they're probably using a PPI or an H2 receptor blocker. Again, we're going to go off of the slides because that's directly from the teacher. So that's what we're going to go with. Remember, antacids can be taken with PPIs, but not with H2 receptor blockers. H2 receptor blockers and PPIs, they don't, I'm sorry, H2 receptor blockers and antacids, they don't agree. They butt heads and they end up canceling each other out. Right? All it's doing is that big thing, aluminum, right? It's not really absorbed. That's actually why that guy turned blue. It's not absorbed well. It's not really broken down by the body, so that's why it causes a color change in your skin, which is seriously look that up. That guy really was blue. Um, uh, it all it does again, it's just neutralizing stomach acid, which is why I highlighted. This is just one giant freaking info dump. all it is just saying that it's just raising your pH. It did mention that again, calcium products are absorbed well, magnesium ones are. So those can go to high levels of calcium and magnesium, but aluminum, you don't really absorb aluminum well. So you just defecate it out, or it stays in your skin for some reason. You turn blue, but whatever. But not with these drugs. I'm just constantly referring to that guy because it was interesting to look at that guy. Long story short, right? They have no reduction of acid production again because they're only leveling it out. It's like in chemistry when we did experiments. You put bases and you put buffers and acids, and it's like changing things, but you're not really doing anything major. Long story short, right? These drugs, they're meant to be taken way after or before, like 2 hours before or after any drugs. Because again, antacids, even though they're not affecting acid production in the stomach, they're still alternating the drug or the environment in the stomach, right? So now you're not as acidic. Drugs aren't really going to be, um, they're not going to be absorbed as well, especially those anti infectives, which are very important. So you probably should take these with like a 2 hour window out. Remember that. Category C drug. Again, seems like you probably shouldn't be taking this if you are pregnant. Probably not. You shouldn't be. But again, if the necessity is that demanding, again, it all depends. Does the doctor clear it? Did they not? It all just depends on that. Adverse effects. Again, constipation. We said that. There is aluminum products tend to bind with phosphate. If an aluminum binds with a phosphate, right, because they're metal and then like they have a tendency to kind of like cling onto metals, that could cause hypophosphatemia. So that's something interesting that it's only really referring to aluminum hydroxide. Aluminum likes phosphate, they both merge. That robs the phosphate from going into the blood, and now you can have low levels of phosphate in the blood. So that is something interesting that is only unique to aluminum hydroxide. Um, again, you need to watch out because phosphate is very big, and those who are at risk are for people who are malnourished. Again, it makes sense because they're not having anything in their system already. Um, alcoholics, alcoholics typically have a lot of issues with their liver, ammonium like buildup, loss of phosphate. So got to watch out with that. And then patients with CKD, because again, a lot of CKD patients are very sensitive to a lot of things. So you have to watch out with them and be very careful how you handle things like that. So you watch out with that, and you probably don't really want to um, use these for a very, very high dosage for these types of patients because you don't want to rob them of that phosphate. Um, should not be used by a patient with a bowel obstruction. Why could that be? They cause constipation, right? And there's already an ongoing bowel obstruction. That's just going to make it worse, which is not what we want to do because they can run the risk of turning that into impaction. And then now we got a real problem. And that's when that digital rectal exam has to come in. um, drug interactions, right? Again, mentioned before, probably important. Do not take with other drugs. Take them 2 hours before, take them 2 hours after, but do not take them with drugs because they're going to lower absorption. Um, use of these types of drugs, right? Like, look, sodium polyestrine, right? Sulfonate kind of sounds familiar. It was regarding potassium, if I recall right. Potassium was used to remove I'm sorry, this polyestrine was used to remove potassium and exchange it to sodium in poop to lower hyperkalemia. We said that potassium was a little acidic in the context of our body. So if you're using antacids, which have the tendency to create your body or make your body alkaline, and you're using a drug that's getting rid of acid, that's probably going to lead you to systemic alkalosis because now you're throwing off your acid levels in your stomach, right? You're making them alkaline, and you're also pooping out more potassium. Draw the connection, and now you're going into alkalosis. Um, Gastrin, right? And urinary pH, they may go up. It makes sense, right? You're taking these antacids, they're making everything alkaline. Urinary pH is typically a little bit more lower on the lower end of, like 5, like 4 to 5, if I recall right. It's supposed to be a little acidic, right? Because there's a lot of H protons in there, right? But if you're taking a lot of these antacids, they're actually raising your pH. Same thing with your gastrin. You're bringing up the pH in the stomach. Um, Again, it messes with iron absorption, just like we saw with a lot of these. You alter, and it's not because the drug directly does that. It's just because you're altering the environment of the stomach that is reducing the ability to absorb a very important electrolytes and vitamins and nutrients that you need to make other things. Same stuff applies. Anemia, you could become anemic, you could have a lower CBC, but I mean, it doesn't really happen with these because they're not doing that for a long time. But I guess someone that's like abusing these drugs, they could run into that risk. Role of the nurse, right? Here we go again. Check medical history, over the counter drug, prescription drugs. We do that all the time. Assess the patients for renal insufficiency again because we want to watch out for any of them that may be, taking these at high dosages and now losing those phosphate levels that are very important that was mentioned up there. Magnesium and aluminum based products may cause diarrhea. You see, there's that weird, kind of like contradiction. Up there it said constipation, but now it says diarrhea. It's a little hard to know which one they do. I'm not too sure. I mean, we looked up information. It said mainly magnesium and aluminum. Those cause diarrhea, but the upper sides are like, hey, it caused constipation. Okay, so we'll go with constipation again. It's a little hard. We'll try to get that clarified and see what it goes. Um, and then there it is. Look, there it is. Freaking calcium causes constipation, what we said earlier. So it's like weird. This one is kind of more in tune with what we found in our research, but because the slides say it earlier, it's a little hard to say. But hey, it's in the slides, so we got that was the information we were provided. Mhm. Alrighty, so now we're pretty much kind of reaching the end here for the PUD drugs. We're kind of close to the end, funny enough. Actually, this is the last slide. There you go. Look at that. Miscellaneous drugs, right? So they're not exactly in the same categories as the PUD. I'm sorry, the PPIs or the H2 receptor blockers or the antacids, but these actually do some pretty big help too. Sucralfate, carafate, right? We're gonna provide the grid that we made a little earlier, that was mentioned a little earlier. We're gonna provide that along with this video to help everyone go with it. But to try to remember sucralfate with carafate, right? We pictured sugar, right? Sucra, sugar, cara, which is like Spanish for face, and we actually used a little photo of a little girl eating a lot of sugar. So we're gonna go ahead and just show a little teaser of that, right? She ate a lot of sugar, and she's just stuffing her face with sugar. Um, this drug, biggest thing that it does, right? It's not necessarily something that's going to help like 100% or like treat peptic ulcer disease, but it helps as a assistant to all the other drugs. I mean, after all, we had that big acronym at the beginning that had all those different drugs that help PUD. This one, it is inhibitor of pepsin, right? Mainly, like it's not gonna stop a peptic ulcer, but it can inhibit it a little bit. And the way it inhibits it, and it's again, you're not preventing production of pepsin, you're just holding pepsin off. That's really what's going on, right? What it is sucralfate is a mixture of sucrose with aluminum hydroxide, which is what we just mentioned that right now. It's the antacid, that alternagel. And that mixed together creates, when it touches the hydrochloric acid in the stomach, it creates this thick paste in the stomach, mainly where that ulcer is. Like it like kind of digs in there, like it stays in there. So like imagine there's a gap in here. Well, that drug kind of like packs into that gap, and it creates this like thick sludge that is like I guess a synthetic mucus if you think about it, right? And it protects that stomach lining that is being hurt by the peptic ulcers, so it helps like therapeutically to help heal. It promotes healing by covering that area with that like sludge, right? Um, so there's with that. There wasn't a lot of information besides this. If I recall right, this drug does need to be given pretty often because it's still an antacid. It's antacids don't have a long like window of use, so you have to use these very often. They could cause constipation as well, if I recall right. That's kind of really it. There wasn't really much about this drug. It's a therapeutic drug. It's a very helpful therapeutic drug, but that's generally kind of it. At least the most important things. There's also misoprostol, which is cytotec, right? It inhibits acid production and it promotes production of mucus, right? Like, and it stimulates it. Again, that's kind of with a lot of these other drugs, right? But PPIs and H2 receptors, they mainly inhibit acid production. But the special thing about misoprostol, cytotec, is that it also does that, but it also helps create more mucus. And the mucus is basically what carafate is trying to, I guess, like replace, if you think about it. The other one that's very important, metoclopramide, Regland. This is a kind of a common drug that I've been seeing in my clinicals. I'm not sure, mileage varies on everybody, but I've been seeing this one pretty often. Um, what's going on is that it has three uses. It can be used for peptic ulcer diseases, mainly with GERD, like problems with GERD. That's the big one. Um, remove the peptic ulcer disease. It's not really that, but it helps with GERD. And then it also helps out with people who have gastric paralysis, like their stomach doesn't really work. And we'll get into why it does that. And then it does help out with patients who are nauseous and vomiting. But in the context of this one, we're mainly going to be looking at GERD. But don't forget that paralysis one, because that's a pretty big one. The reason why this occurs, metoclopramide happens to be a dopamine inhibitor, like a dopamine receptor blocker in a way, right? That helps kind of like promote, because we said GERD is the weakening of the esophageal sphincter, right? We said that. So the sphincter is opening, right? It's like relaxing. We can kind of associate dopamine with relaxation because it's like happiness or like a quick rush of happiness or whatever, right? So if you block it, it's gonna keep it uptight. Like the muscle will be stimulated and contract, right? Like it'll close that gap, which is what this drug does. It promotes muscle contraction on the upper GI. So how it stops GERD is right. Like GERD is like the sphincter's open. Here's the stomach, and like things are bubbling out, right? So if you make the sphincter close, can things get through? They can't, not anymore. Another thing too, this helps out with the nausea and the vomiting by kind of getting rid of what you can vomit by increasing emptying of the stomach, right? So like here's your stomach, right? It's full of food. You just close the esophageal sphincter, and now you're dumping out the thing in the stomach in the duodenum. Do you have anything to really vomit? Not really. Um, Again, it being an anti-dopamine drug, or well, anti-dopamine receptor or whatever, it's actually very similar to other drugs that affect dopamine that have to do with nausea and vomiting. But we'll talk about that later. Um, but that's where just the biggest thing with this one. Now think about it. We are basically inhibiting dopamine. What is dopamine? Dopamine is a chemical messenger in our body, the same way how we use acetylcholine, we use serotonin. Those are very important. If you inhibit things like that, and I'll use the example that was made in my physiology course. When a person does not have enough dopamine, you get Parkinson's disease. If you guys recall that. Obviously, a lot of Parkinson's has a lot to do with paralysis, dyskinesia, and that's where we start going into how do you say tardive's dyskinesia, and you start having a lot of issues with the central nervous system. It can make a person have suicidal thoughts. It can cause depression. It can cause a lot of. It's weird how this drug does that, and like in the effort to get rid of GERD, get rid of, uh, or like help with paralysis, right? Because if the stomach is not working anymore, right? Like it doesn't function. If you use a mechanical thing via chemicals, right, forcing the stomach to empty, you're kind of like using a drug to do the stomach's job. That's where it plays that part. But again, this has a lot of side effects with the central nervous system. So, in the grand scheme of things, to finally just finish up, metoclopramide has three different functions. It can help with GERD, it can help with stomach paralysis, and it can help with nausea and vomiting. It helps with GERD by making the esophageal sphincter close. It helps with paralysis in the stomach by emptying the stomach. And it can also help with nausea and vomiting as well by closing the, if you kind of think about it, like close, because it closes the esophageal sphincter and then it empties out the stomach. You don't really have anything to really puke out if you think about it. But it is an anti-dopamine or like a dopamine blocker, antagonist, whatever. If you do something like that, we've learned if you mess with the central nervous system, you're going to cause problems. That's where you get the tardive's dyskinesia, you get the suicidal thoughts, you get all these different problems with the central nervous system. So that's essentially it. With these drugs, right? I mean, after all, we're saying this messes with the central nervous system. Given with IV, you can cause palpitations. And think about it again. We said cimetidine causes problems with the central nervous system. So when it was given to people, cimetidine, remember we're talking about cimetidine, that other drug that was already talked about a little earlier. When given by IV, it caused dysrhythmias, it caused hypotension, messed with the central nervous system to cause these things. It's the same thing with this one. This one's messing with the central nervous system. IV is just like a stronger way of doing it. It can cause palpitations. And then PO drugs, I mean, those are a little bit more on the safer side, but they still have that. And then if you empty out the stomach more, right, you could cause diarrhea. You're kind of like forcing peristalsis and like forcing everything to go out. It could cause diarrhea. And that's generally it for our peptic ulcer drugs. All right, everybody. So there is a possible solution to that whole weird thing with the antacids about it. Like, does it cause constipation? Does it cause diarrhea? Which is it? So we looked into it a little bit, and online resources kind of pointed towards this direction. This was kind of overlooked a little bit. This little part that I just highlighted that's brand new. We said aluminum can cause constipation, but not really diarrhea. That's what the resources are saying, and it's starting to make sense. It's starting to click a little better, right? Because it says here combining aluminum compounds with magnesium increases the effectiveness, obviously, because now you're making a more antacid effect. But in terms of side effects, now it's reducing the potential of constipation, right? But now, what happens when you go from one end of the spectrum of constipation and you go to the opposite? Now that's where something like this is where it was talking about over here with where's it one more. Oh, that's where this comes in. So what it's saying is magnesium in conjunction with use of aluminum products, something about magnesium and aluminum being combined can cause diarrhea. Because again, now you're going from one end of the spectrum to the other. What's the opposite of constipation? Diarrhea. So that's why this is going on. Wording was a little confusing, but we may have figured it out. Hopefully, it is that we will confirm and then say what we find. Alrighty, so now we're getting into chapter 42, right? And these are all what we talked about. 41 was all about kind of upper GI. Now we're getting into lower GI. Well, kind of lower, but I mean, it's regarding down here, right? Mainly, we're going to be talking about constipation and diarrhea. That's like our big one. So moving on, right? So the lower digestive tract, right? We're not really talking about the stomach anymore. We're now at the duodenum, which is that small intestine. Next thing after that is the jejunum. Then after that, it's the ileum. Then the colon, right? The large intestine. So big thing. Peristalsis is controlled by the autonomic nervous system, which makes sense, right? Makes 100% sense. After all, that's what we need. Our CNS works, sends all the messages. It promotes peristalsis when you are in, like when the autonomic nervous, like the when you're in sympathetic nervous system response. Are you really digesting? Not really. When you are in parasympathetic, are you digesting? Yes, you are. You know, that's all controlled by the autonomic nervous system. So that will actually play down the line further as we start kind of touching on drugs that have a lot of effect on the central nervous system. So that's just a quick teaser. And then it's just talking about how peptic ulcer is the most common disorder. We talked about that in 41. Now we're going to get into constipation, right? So constipation, big thing with constipation and diarrhea. Just to be full frontal, these are not really diseases, they're more symptoms of something going on. That's what was all referring back to that whole thing about the autonomic nervous system, right? Is diarrhea really a disease? Not really. It's more of a symptom. There's something bigger going on. So typically, the main goal of a lot of these treatments is these drugs that we're going to talk about, they treat the symptoms, but they're not really treating the disease. So the most important thing would obviously be treat the disease, whatever's going on, whether it's a CNS issue, a bacterial infection, some kind of problem of some sort. It's better to get that ahead, but you still want to treat the symptoms as well because you want to make your patient comfortable. Constipation, a lot of causes can be lack of exercise, right? You're not really moving your muscles. After all, you need to use them or lose them. Same thing with your bones. You're supposed to be working out if possible to kind of move your muscles and also move your bones, kind of break them down, and then hey, build back up. And then the same thing with your muscles. So if you're not really using your muscles, you could lead to constipation because peristalsis is basically gone. And then if you don't have any peristalsis, any movement of food in the stomach, that food just stays there. What happens to the food? The large intestine just absorbs all the water because after all, that's what the large intestine is supposed to do. It just reabsorbs water. You keep taking water away from that poop that you have, and now you have a stone. And then that's how an impaction occurs, right? Another thing too, insufficient dietary fiber, right? Fiber, it's not really, it's not something you absorb, it's not something you break down, but it happens to help with, like attaching itself to poop. And fiber is a kind of like a hypertonic kind of substance that attracts water to it. So if you have fiber in your stool, it will help kind of moisten up the stool to kind of help it make it easier to pass, which will actually be one of our drugs we're going to talk about that helps with constipation. But there are certain things you have to watch out with it too. Diminished fluid intake. Again, if you're not drinking enough water, your stools are going to be dry. Your stomach, your large intestine, I'm sorry, is already absorbing so much water from the stools that you're making. So if you already don't have enough water as it is, especially when you eat, you're just going to dry that food out even more, or not food anymore, it's poop. Slow motility of waste through the large intestine. Again, it could be caused by the lack of exercise. That's, again, low peristalsis. The food stays in there for longer, it slows down. The large intestine absorbs all that water, and now you're left with that stone. And then certain foods, medications, and diseases, as always. I mean, we just talked about a couple of the meds that cause constipation. Funny enough, look at that. Diarrhea. I mean, I don't really think we need to go that far in depth to it. It's just more frequency of BMs, more fluidity. You're not really absorbing or reabsorbing water. It could lead to electrolyte and acid base imbalances, right? Remember that? Like diarrhea can lead to um, acidosis because your stools are a little bit alkaline, or just a little bit, right? So if you have too much constipation, you could be systemic alkalosis. If you have too much diarrhea, you can lead to systemic acidosis. It could also be seen as a type of body defense, right? If a patient has C. diff, you don't want to really stop them from having diarrhea because that diarrhea has C. diff. You want to get rid of C. diff. If you're stopping the diarrhea, it's just sitting in there, and now C. diff is just flourishing in there. Um, so actions of laxatives and cathartics. So we're now going to get into drugs that treat constipation, right? There are laxatives, and laxative is an umbrella term for the most part, right? It doesn't always mean just like forcing you to have a bowel movement. There's different approaches. It's not always just about forcing the patient to go. Um, but long story short, they treat constipation, right? We need to use, there's the safer end of the spectrum, and then there's a more forceful end. Those forceful ends are called cathartics. They're also known as purgatives, right? Purge, you're purging, you're like forcing it out. It's a cathartic, like, I don't know, cathartic just kind of reminds me of just forcing things out, but purgative is a big one. These are very strong, potent laxatives that will force you to basically have a bowel movement. Um, they're a little dangerous. They come with their risks. Again, they basically can create diarrhea, which again, acid base balance or imbalances. They could cause electrolyte imbalances, so on and so forth. So we're going to go ahead and get right to it. Uh, our safer end. I highlighted these in purple, violet, purple, whatever you want to call it, because these are a little bit more of the safer drugs, right? We have a bulk forming laxative, better known as Xylem. This is an error. This is a typo. It is not Miralax. Miralax is a different drug. Xylem is Metamucil. So I will correct this when I upload these slides. Metamucil is a different drug that's actually very forceful. It is not this bulk forming laxative. That's not it. That's a little bit more of a forceful drug. But long story short, psyllium is basically a fiber, right? It's a fiber that you take in. It's actually used a lot. It could be taken with a lot of different drinks. It could be taken with water. It could be taken with juice. It could be taken with milk. Because it's like a powder form, right? It's basically just supplemental fiber. It softens the stool because that fiber helps absorb more water in that stool. And then it also can create bulk, right? It's in the name, bulk forming laxative. One of the biggest things is that you are not to use this drug with patients who are already constipated, like really, or like, I mean, not constipated, I mean more in just they're impacted. Like they're having an impaction because, right, it's impacted, it's basically a stone, or like really severe constipation, you're not really going to use this because if they're severely constipation where nothing has worked so far and you're adding more bulk to the constipation, that could make it worse, right? And that's the last thing you want to do. This is more of a safer drug, but used for extreme situations is more contraindicated because of that bulk producing capability. You just don't want to make it so they're impacted. If it's really, really, really severe constipation, you probably don't want to give this. Big thing with this drug is meant to be drank with a lot of fluids because, after all, it's basically fiber. Fiber will absorb a lot of water. So when somebody ingests it, they need to drink a lot of water to be able to kind of. And then after all, too, you're trying to have a laxative effect. You need more water. You need to soften the stool. How will the fiber create a softened stool without water? You need more water. That's just an additional thing that you have to take with this drug. Um, Beyond that, It could cause you to strain a little, like not really strain, but it has a tendency to kind of make people pass out a little bit because they're still trying to like push out, which that's not the goal of this, but it is a side effect that could occur with this kind of drug. So it's something to kind of think about a little bit. But there is always a risk with this drug. That is the problem with bulk forming laxatives. You always run the risk of making it worse by having more constipation. So you do need to watch out with that. Again, um, beyond that, it needs to be taken over 1 to 3 days. It's not a very quick effect, but 1 to 3 days is a little faster, than other drugs. And beyond that, you just take supplemental fiber to help you out in order to help make the food or the stool get a little softer and help you go. But always remember, constipation, or more constipation, I should say, is always a risk with this one because of the increased fecal mass, that bulk that you're forming. Stool softeners. These are actually made more of a prophylaxis to prevent constipation. That is where you're having your docusate, your colace, right? And the biggest things that it does is that it's just using surface agents. It's not a fiber. It's just chemicals that help moisten the stool through a detergent action. That's just helping make things a little softer to help them just go a little easier. There's not really much besides that. Um, it's just a little bit more of like a prophylactic drug. That's really what it's all about. So there is to watch out with that. It does cause more water and fat to get with the stool. Again, that just helps soften it. That's that detergent action to be specific about. Um, Beyond that, there's only like simple signs and side effects: diarrhea, abdominal cramping. A lot of these drugs are going to cause diarrhea after all. It's a likelihood. Um, if your patient is having diarrhea, you probably should stop these drugs because, again, they are influencing that type of bowel movement. Um, Beyond that, just again, take a lot of water, always monitor your patient's fluid electrolytes. That's generally it. Not really much. It is safe for patients. Actually, it's used a lot for post birth, because the last thing you want to do for a woman that just gave birth is for her to kind of like strain and then force like a bowel movement out, and then now you could undo like a whatever a stitch. You don't want to do that. You want to lessen the effect of that. So that's with that. Now we're going to our emollients, right? Emollients, like for motility, right? Um, Emollient, I think oil, which mineral oil will be our example because that's what it is. But emollient, right? We think of motility. So the emollients are, all they're really doing is like, have you ever had something stuck on something like a wedding ring, right? Like you've ever had like a wedding ring stuck and you use oil to kind of like get around it and like kind of cover it so you could just pull it out easy. That's kind of what an emollient does. If you kind of look through it, it just coats the stool. It helps kind of lubricate it, and then hopefully gets out a little easier. um, it's really meant for constipation. It's really given when there's no safer alternatives. The biggest things with the emollients is it could cause side effects of diarrhea and nausea for the big ones, right? I mean, it's oil. Like that kind of sounds a little nasty to be drinking that. I've never really used it before, but I mean, it kind of sounds nasty. But most importantly, right, if your patient doesn't have a good ability to swallow, there's always a risk of aspiration pneumonia because it's oil. Oil is not meant to be in the lungs. If they aspirate that, they can get an infection, which is where you have your pneumonia. Besides that, not really much else. You should just take on an empty stomach. A lot of these are actually taken a bit on an empty stomach, but in exception with a couple ones that we'll mention, especially with that the Metamucil, the Xylem. Now moving on to the next slides. This is where we start touching on very strong drugs, right? The ones that are brown are cathartics, those purgatives, those forceful ones. Saline laxatives, right? They pull water to the fecal mass, a little bit more forceful to make a watery stool. That's where that milk of magnesia comes in. That milk of magnesia comes in various different forms. I've heard of enemas, I've heard of PO drugs, I've heard of different angles, but this one can cause. It could cause high levels of magnesium. It could cause hypermagnesemia because, after all, it's magnesium. So always watch out with that. That's always a risk. And again, a lot of these cathartics, they run the risk of dependency. And if you become dependent on these drugs and you use them chronically, they will cause you to have constipation, chronic constipation, when you're not using them, because now you've basically just turned off your entire um, large intestine on how to work, right? Now it's not working that well. So now you're needing to use these because these are the only thing really moving you. Um, so in terms of our milk of magnesia, right? It's very effective. It could be used for colonoscopy, perhaps. Actually, the saline laxatives are very big on that, and it could also help with purging toxins out of the body. Other than that, I mean, there's not really much else other than just chronic use with can cause constipation, it can cause diarrhea, and that diarrhea can cause electrolyte imbalances. There's not much else to go about that one. Stimulant laxatives, right? So the difference with stimulants is that, we've mentioned before that it's more effects on the stool, right? Well, stimulant laxatives are kind of, I think they're the only laxative that actually forces peristalsis in the stomach. It actually messes your with your cells, your smooth muscle cells, to kind of get things going, right? That's where we're going to have our biscadil and our senna and castor oil. These could come up. It's possible. Um, so you do want to watch out with those. And it's basically it's just forcing the strong activity of peristalsis that can cause um, you just poop out like straight up. Um, you always need to run a risk. Again, long-term use can cause constipation. Abdominal cramping is always a side effect that could occur. Patients could faint because it's such a strong drug that, like, they could go vagal. If anything, it's possible. I mean, it's not directly with that, but it's very likely that it could happen. Um, Beyond that, I mean, just diarrhea, um, fluid and electrolyte loss, and the dependence. There's nothing else to really go about. These are kind of simple, straightforward drugs that you just need to know more their action of what is going on. Now we're kind of finishing up osmotic laxatives, right? These are a little different because now they're actually driving water from tissue. They're very hypertonic, I guess you can say. They mix with stools, or they can be separate outside in the lumen, where this is your large intestine. What's in the middle, that diameter is called the lumen. It forces fluid out of the tissues into that area, so it's causing more water to be in. It kind of like mixes it up, and that's where you get that lactulose and that polyethylene glycol. This polyethylene glycol is Miralax, in addition to the trade name of Golightly, right? Lactulose is very important, right? Because that is Cronolac. Cronolac helps us remove ammonia levels in specifically patients that have liver failure. So that is a very big and a very important laxative. Lactulose is specifically for the treatment of high ammonia levels in hepatic failure patients. That is specifically for that one. Lactulose, trade name Cronolac. Or if I recall right, it's the other way around. Is it? Oh, no, it is. Oh, yeah, okay, yeah. Cronolac is the trade name. Um, Very big on indication for that one. Lactulose is almost like special for that one. Polyethylene glycol is used for a lot of diagnostics. Again, it's the same thing with the other drugs in terms of colonoscopies. So that's a big one. It's used a lot to the point where it's like, oh, go lightly. It doesn't really go lightly on your stomach. Apparently, it's very strong. So, and it's used to the point where the patient is only really defecating water. So they're like just straight up like having diarrhea of water. Um, mm, mm. Oh yeah, yeah, yeah. So lac at the beginning of lactose or lactulose, and there's that chronolac which ends with lac, right? That kind of helps us remember a little bit. Um, Beyond that, there's not really much else to go about. There's it's just remember this one is for ammonia. This one is for helping out with diagnostics and forcing out until the point that you're pooping out water. Last but not least, we have a chloride channel activator, right? It's called lubiprosterone, right? This type of drug increases intestinal fluid secretion by activating those chloride channels, which is basically just like making cells work a little harder, and it just makes more fluid go in there. Kind of really it. There's not much else to go really about it. Um, it could help with IBS. That was a big one with it. But IBS constipation, not IBS diarrhea. You don't want to use it for that. Same side effects as all abdominal cramping, diarrhea. There's not much else. Um, Relief is given in 24 to 48 hours, so it does take a little bit longer of an effect. But we do want to think like lubiprostone, like we're lubricating the colon, lubricating lubiprostone, kind of like that. Don't mix it with the mineral oil that is lubricating the poop. This lubiprostone is more lubricating the colon itself. Moving on, right? So role of the nurse, laxative therapy, right? So peristalsis must be restored prior to laxative therapy. The main reason why is like again, without peristalsis, that BM is just staying in there. The stool is just in the colon. You need peristalsis in order to help. These drugs will get you to the exit, but they still need that peristalsis to occur in order to get it out. Colon cancer is a big thing, esophageal obstruction, mainly for that xylem, intestinal obstruction, fecal impaction, undiagnosed abdominal pain. You never really give these drugs for that undiagnosed abdominal pain. You don't give them for impactions, nor do you give them for obstructions. When given for obstructions or these types of drugs, you run the risk of perforating of bowel because there's too much buildup of like force in the colon. Like imagine this water bottle is your colon, right? And you're just increasing the volume. Have you ever seen like a bottle just keep inflating? What's going to happen when you're just increasing all that pressure in the bottle? Eventually, it's going to burst, and that same thing will happen in your stomach if pressure keeps rising too much. That's the reason why you should never give these drugs for fecal impaction, obstruction, or abdominal pain. You could with constipation, but you have to tread carefully and make sure that these are ruled out. You want to rule those out because the last thing you want to do is blow up a patient's colon. If diarrhea occurs, again, you stop it. You've achieved what you wanted. You don't need to keep giving it to them because now you run the risk of giving them electrolyte imbalances. Um, give with 1 to 2 glasses of water. Makes sense. Take more water. Help out. Get the stools getting softer. Use with caution with pregnancy or lactation. Again, these can cause you to force to go. I don't think that would be good for a pregnant patient. Beyond that, accessibility to swallow comes again with the xylem. Those can cause issues with swallowing. And then beyond that, for patients who are having constipation, the most important thing, the first thing, as always, we always go with the least invasive procedure first. That is recommending a lifestyle change, telling them to drink more water, take more dietary fiber, um, move around a little more. Let's see. Yeah, move around a little more, to reduce the likelihood of them having to use laxatives and end up becoming dependent to them. Now we're going to get into diarrhea, right? And it's pretty short, and there's not really much to go about for diarrhea. Um, Opioids are typically going to use for diarrhea, and funny enough, they're kind of the only thing that was really indicated for this. Opioids, what do we learn about them, right? They're CNS depressants, right? They shut down the CNS, or not really shut down, but they have the capacity to do it, right? So opioids are going to be very big on that. Now, for mild diarrhea, we would use things like loperamide, right? That's Imodium, not ammonium. Imodium. I think I've seen those Imodium salt boxes. They're kind of like something a lot of people or a lot of stores sell. The bismuth salicylate, or subsalicylates. Those are just Pepto Bismol. And then you want to use lactobacillus because again, if you're having too much diarrhea, you could run the risk of getting rid of your normal flora, and now you could have C. diff come in, and that's really bad. So for mild diarrhea, you would give ammonium salts-at-loperamide, the Pepto Bismol. Just try to remember the bismuth subsalicate, and I mean, I've seen Pepto Bismol so much that this is like kind of secondhand now. Mileage varies with everybody, but you do want to get the lactobacillus. Those are for mild diarrhea. Now, if the diarrhea is really really bad, that's when you would give opioids. Obviously, you want to assess their fluids and electrolytes. You don't want to overdo it. Like you want to know your baseline. You don't want them to have some kind of imbalance. Assess for blood and stool, which makes sense. Um, do not use if constipation should be avoided, right? So if the main thing is like, because these drugs, the opioids can actually cause constipation. After all, that's what we learned. So if it needs to be avoided, probably shouldn't use them. And then assess the patient's ability to get out of bed. Kind of makes sense. They're gonna have to go. So if they can't make it to the toilet, then there's gonna be a problem. Maybe give them a commode. So now we're going to get into the category of antidiarrheals, right? And this is our opiate agonist, right? So all it is diphenooxate, oxalate, which atropine, right? Which is the brand name is low motil, right? Low motility. That's what we're going to be remembering, right? In the end, opiates slow peristalsis due to the action of basically lowering CNS production, right? Like CNS function. Um, what was something that we learned with with opiates? They cause a lot of dizziness and they can cause drowsiness because again, your CNS system is lowered. So that's kind of things that happen. I mean, adverse effects, that's kind of standard with all freaking opiates. And we can just move on to the next slide. So this diphenooxalate, right, with atropine. So the diphenooxalate is the opioid in this drug, and the atropine is actually it's called a anticholinergic. So cholinergic effects are typically things where your body is making secretions, it is making you go pee, it is making you go like have bowel movements, it's making you secrete like saliva and stuff like that. So atropine, being an anticholinergic, basically goes against all that, right? So it can make your mouth dry, it can actually make your heart race, and we'll kind of touch on that in the coming weeks about what anticholinergic effects are a little bit more. But long story short, right, it's just slowing the peristalsis, right? It's allowing for more water reabsorption because if you're slowing peristalsis, we talked about that in constipation, the poop is moving slowly, so now there's more chance to absorb water by the colon, or reabsorb it, I should say. Um, Obviously, it is not recommended for children or infants. It is an opioid after all, so there is always a risk of it. It is a safer drug. The risk of dependency is not really there, but it's an opioid nonetheless. The last thing you want to do is overgive these, right? The atropine, right? Again, it's given to discourage. That anticholinergic effect is discouraging patients from want to take it too much because again, it causes you to have a heart like a rate uh, like palpitations, tachycardia. Basically, it's making you kind of like nervous and stuff. It can cause your mouth to be dry. It's making you drowsy. Again, it's making all these different effects that are making you not really want to take the drug. So it's like a deterrent if you think about it. So there's like no chance of abusing these opiate drugs, right? Um, and if you want to do a little bit of research, anticholinergic drugs have a lot to do with the like fight or flight, sympathetic and parasympathetic nervous system. Um, Again, as soon as diarrhea symptoms are resolved, they should stop. Like there's no need to keep giving these drugs if the symptoms are gone, right? Um, if giving to children, right, they're not typically going to be given, but you need to dose them very accurately. Hopefully, it never comes to that, but obviously, you need to use proper measuring tools, and that's it. Category C drug makes sense; it's an opiate. Beyond that, it contains no pain reducing properties, and it has a low potential of abuse, but still, it's an opioid, right? It can cause dizziness and drowsiness. It still gives you those effects of CNS depression. Contraindications would be obstructive jaundice, right? Because that could be an issue with your liver. Your liver processes opioids, so the last thing you want to do is, patients having liver issues, giving them an opioid. Diarrhea associated with PMC, that is pseudomembranous colitis, which is basically like something that occurs from C. diff, and that's really bad. I mean, that's something I've just learned, like, oh, stay away from that. Severe dehydration, again, electrolyte imbalance, right? It should be corrected because, again, this everything has to be fixed prior to really giving these drugs, especially if they're having diarrhea. Like, first fix the electrolytes, then fix the whole thing about the diarrhea. Like, it's like, what comes first? Obviously, fix the electrolytes. Drug interactions, right? For the most part, I mean, if given with other CNS depressants, they're just going to make it worse. Things with using with monoamine oxide inhibitors, those are going to cause hypertensive crisis, which is going again with the whole thing of the atropine. It goes with the whole making your heart kind of race and stuff. Again, it's a sympathetic response. Um, it can cause serum amylase, which again, that's more related to kind of like production of removing carbohydrates. That's kind of interesting. But other than that, overdose, Narcan for opioids. Alrighty. Now we have irritable bowel syndrome, right? Sorry, a little technical difficulty there. So yeah, so irritable bowel syndrome, right? Common disorder of the lower GI tract. Funny enough, this is actually called functional bowel disorder because your organs are still really working. It's the process of how irritable bowel syndrome occurs is a little unknown, unfortunately. But sometimes when it comes down to it, it's just one day, you're having diarrhea. Next 3 days, you could be constipated. Next 5 days, you could have diarrhea. It's constantly alternating. The main thing, right? Abdominal pain, cramping, bloating, gas, which are basically just your signs and symptoms of diarrhea or vomiting or constipation, right? The bloating, the cramping, the gas, those are constipation, right? Abdominal pain, that's your diarrhea. Those are all just going to be, the main thing that it comes when treating IBS is just whatever is making things worse, or like the dominant symptom, right? Like the dominant, is it, what's worse, your diarrhea or your constipation? That's what's going to get treated. That's really the only thing that can really be applied to these to this type of disease. Unfortunately, again, it's functional bowels, like you're still working and everything. It's just kind of unknown how to really fully approach it. So again, it's more supportive, simple symptomatic treatment, right? Again, you're just treating really the symptoms. You can't really fix the problem, but you could give anticholinergic medications for IBS-C, right? So those anticholinergics, again, they help stop. Their basic anticholinergic is somewhat synonymous with sympathetic nervous system response, right? So if you're having a sympathetic nervous response, are you really going to be having a lot of bowel movements like with diarrhea? Probably not, or this is actually a little error. So we're going to fix this in a little bit because it's more for diarrhea. That's what the anticholinergic is, but I'll fix that up in a little bit when I share the slides. But long story short, yeah, just omit that. For this would be for the diarrhea. But again, supportive treatment, really just treat the dominant sign and symptom. Now we're going to go to inflammatory bowel disease, right? So you have your ulcerative colitis, which is basically ulcers in the large intestine. We talked about how PUD is all about gastric ulcers, duodenal ulcers, while ulcerative colitis is all about that ulcers in the large intestine. Crohn's disease, right? That's ulcers in the distal part of the small intestine, so that could be the ileum, right? Because the ileum is before we go into the large intestine. So symptoms are mild to acute. Just they vary. And there's not really much else. There's remissions and exacerbations. Again, it's just ulcers. Like it's just ulcers, but in a different part. It's not duodenal and it's not gastric. They're not your PUD. They are going to be your ulcerative colitis, your large intestine, Crohn's disease, which is that last portion of the small intestine. Treatments to these, they seem like a lot of them glucocorticoids, immunosuppressant drugs, right? They seem like this almost kind of sounds pretty much like what? I mean, what do you give these for, right? These would be for autoimmune kind of related things. So I'm not too sure about that, but seeing how glucocorticoids and immunosuppressants, they both cause immunosuppression, kind of interesting about that. Besides that, there's 5 ASA agents. That one's kind of just out of left field. So I guess that one, unfortunately, you just kind of have to memorize if it comes up on the exam. Moving on to the next slide, right? So C. diff infection, right? So we have, again, the signs and symptoms: abdominal pain, tenderness, watery diarrhea, nausea. This is basically your signs of superinfection, basically, right? Um, it's either caused by the eradication of your intestinal flora by the use of antibiotics, or the overuse of proton pump inhibitors and H2 receptor blockers, which we talked about earlier in the video, where again they're increasing the pH of the stomach, right? So now you're getting rid of that natural defense system that we have. And it's basically allowing microbes to come in and flourish. Again, good hand hygiene. Always good to have good hand hygiene, as always. Increase taking, yogurts that have cultures in them, like lactobacilli. So probiotics, long story short, you know, and it's don't use antidiarrheals when it comes to this because again, you want to get rid of that C. diff, right? You don't really want to stop the infection because if C. diff is in the stomach, the whole or the GI tract, you're trying to get rid of it. So if you use an antidiarrheal, it's just going to get stuck in there. Now, it's not going to go away. Again, metronidazole, vancomycin, those are the ones that you mainly are going to use. It's all about prevention. Again, you want to be careful when using like things that can cause C. diff. Always watch out. That's where the hand hygiene. Use things like they're supposed to properly. Don't overuse anti-infectives that can lead to this. Like, people who are immunosuppressed, blah blah blah, so much and so on and so forth. A lot of that has to do with C. diff infections, right? But again, this is very pivotal. Do not use antidiarrheals for patients with C. diff because you want to promote getting rid of the C. diff. You're just gonna with antidiarrheals, you're just gonna leave the C. diff in the colon, and that is not ideal. We're kind of finishing up a little bit. I mean, this is the last little big portion of when it comes to this chapter. Vomiting, right? It's emesis. That is like its formal term, right? There's a lot of different things that can cause this. First and foremost, disease. Another thing too is pain or psychological factors like heavy emotions, changes in body position as well. If you think about it, right? Sometimes you can kind of get up a little bit too early, and you have orthostatic hypotension, and that can cause you to get like really, drowsy, like dizzy, and then it makes you nauseous, and then you vomit. Right? There's different factors to that, and then excessive vomiting, right? It could lead to dehydration. It could lead to acid-base imbalances. I'm sorry, and then it could lead to electrolyte imbalances, right? There's so many different things that can occur, right? And then if the acid base balance is so bad, it could lead to that vascular collapse. Again, it's just your body's just shutting down completely. Um, again, like acid, too much acids that causes your body to shut down. Too much alkaline that causes your body to get too stimulated. There's so many different ways that this goes, right? But dehydration, significant weight loss, especially because it's too much vomiting, right? Because you're vomiting water. Water makes up a big portion of our weight. Um, and then there's all that stuff with the metabolic alkalosis. So you just again, 3 big points: acid base imbalances, electrolyte imbalances, and then it can also cause the dehydration. Um, there are going to be 3 different categories when it comes to antiemetics, right? Anti vomiting. They are going to be serotonin related, which is the ones that end with citron or yeah, citron. So ondansetron, that's Zofran, right? Then we have dolacitron. I kind of think of like my aunt, Ansmet, right? Ans like a, like no, and then ement, which is emesis, if you think about it, right? But I like to think my aunt, because this kind of looks like the word aunt, my aunt Dolores, Dolacitron, my aunt Dolores. That's kind of one way to look at it, to kind of remember. I remember ondansetron being Zofran because that's something that in my time working in healthcare, I've just seen that so much. A lot of people in healthcare have seen this type of drug. It's a very, very common drug. This is one that you kind of should just know by the back of your hand. Again, a lot of practice, a lot of relooking at it, and you'll be able to get the hang of it. So the big thing with this one, right? So serotonin blockers, right? This is basically what it is, right? It's an antagonist to that, right? Long story short, inside of our brain, there is a specific area called the chemoreceptor trigger zone, right? And that trigger zone has a vomiting center within it. If that is triggered, that causes you to vomit. Serotonin, as we've mentioned before, along with dopamine, which will come up soon, and acetylcholine, which will somewhat come up soon too, those all have to do with chemical messages being sent within the body to the brain, right? Because it's a chemical messenger for the CNS system, or yeah, so CNS. Um, if you prevent the messages from being sent, either from, you stop it centrally here, they won't send the message back, hey, we got to vomit. So that's what's occurring in this case. You're basically kind of shutting off that that reflex, I guess, because the messages aren't being sent by the brain to the muscles here in the GI tract, right? The biggest thing with this one, though, right, is this one is more related, at least the book made it more about post surgery vomiting prophylaxis and chemotherapy vomiting prophylaxis. That was very big in this chapter that mainly pointed this one to those kind of situations. So watch out with that. I'm not really sure how questions will go, but this book was just very heavy on the emphasis about chemotherapy treatment, prophylaxis for vomiting, and post surgery, post op of surgery prophylaxis. Um, Again, they can the interesting thing with the serotonin receptors is they can stop it centrally here in the brain or peripherally in the abdomen where the GI tract is. That's what's kind of interesting. It can stop it here and it can stop it here. In comparison to a drug that we're going to talk about a little bit that only really seems to stop it up here in the brain rather than in the abdomen. So that's pretty much it with this, right? And look, there it is. There's a chemotherapy. Here's a post-op stuff. So it's very big on that. Even though Zofran is used like heavily by like kind of almost every hospital, like nonstop over that kind of stuff. So kind of weird. Um, Beyond that, right? So we have antihistamines, and they have an anticholinergic effect. In the end, all of these are basically kind of anticholinergic effects because you're trying to prevent secretions from being made, right? So you're kind of using this like it's better not to dive in that way. But long story short, these are sources vary. Sources kind of vary. Sometimes, they say this one is a antihistamine, but then other ones will say anticholinergic. So it's a little weird. But long story short, we did have a little graph in again with our MedGrid that will help us remember these names and remember the antihistamines and all that stuff, right? So for this one, the big thing that we use for the antihistamines, right, with the diamond hydronate, right? We pictured an ant that is supposed to represent an antihistamine. I know it's not the best because anti can go to anything, but we're gonna just, for this exam, we'll use the antihistamine. We'll picture an ant, right? That ant is carrying a dime on its back, right? And it is carrying that dime because it wants to buy a magazine that is called Meclizine, which sounds like magazine, right? I know it's a little silly, but to remember the brand name of dime and hydronate, the ant carrying the dime and hydronate, and there's like a little water bottle near it to remember the hydronate, right? Water, kind of water, hydro water. Um, that Meclizine is a drama it's a drama magazine, Dramamine, right? So the ant is also very dramatic. It wants the chisme if you think about it that way, right? So the ant is very dramatic. It's carrying a dime because it wants more drama. So the ant carrying the dimenhydrinate is a dramatic ant, Dramamine. And that magazine it wants is meclizine, and it's also so he can take it to antivert because the ant's name, which is kind of a word salad, is anti-vert. Oh, I got to take it to my anti-vert. I don't know. It's weird. It's like, but long story short on this one, look, anti-vert, anti-vertigo. So big things with these antihistamines. Now that we establish our naming nomenclature weirdness, uh, antihistamines, they have a lot to do with messing with acetylcholine movement in the, like messaging within the brain, right? And something about those, like preventing the acetylcholine with the antihistamines, have a lot to do with motion sickness and vertigo. So when you see drugs like dimenhydrinate and meclizine, those you really want to pair with motion sickness. And these drugs work best when you take them in anticipation of an episode of motion sickness. So there was like situations in the book where it mentioned like, oh, if a patient knows they're going to be on a boat, it is very likely that they should take dimenhydrinate or meclizine in order to prevent motion sickness while on the boat. That was very big on this one. So to kind of review, these, the citrons, the serotonin receptor antagonists, these were very big about post-op and chemotherapy, vomiting and nausea prevention. Antihistamines like dimenhydrinate and meclizine were very big on motion sickness. Obviously, when you have motion sickness, you're going to get nauseous, you're going to get vomiting. But this one kind of takes it a step back and tries to prevent it as a whole by removing that motion sickness or vertigo, right? Antidopaminergics, right? So again, dopamine, right? We talked about dopamine before. These actually have the same side effects as we talked about as metoclopramide, that Reglan that we talked about. Again, dopamine receptor antagonists, they interfere with stimulation of that chemoreceptor trigger zone that we talked about that's in the brain, that's blocking messages to the GI tract. So it seems like it's only affecting centrally. The serotonin ones seem to affect the brain and it affects the GI tract. But it seems like these antidopaminergics, they mainly affect up here in the brain, which in a way kind of makes sense. I mean, serotonin and acetylcholine is a little bit more used like everywhere in the body, rather than just, I guess dopamine's more central here in the brain. Not too sure on that. That's not my area of expertise. I mean, I'm not an expert on any of this crap, but in the end, I mean, it kind of gives you an idea. Long story short, a lot of these anti-dopaminergics, right? Um, they end with azine, right? Azine, right? And this is where we actually get our compazine from, right? So we drew a couple interesting photos for prochloropromazine. We drew up I mean, to help us remember both of these, right? Promethazine happens to be a drug that was abused by a lot of people to make lean, which is what comes in as it's like promethazine with cough syrup and like Sprite and Jolly Ranchers, I think. I don't really remember 100%. Long story short, it's lean, it's purple, right? So that's why it's all purple here, right? So we pictured for prochloropermazine, right? Compazine, right? We pictured an OG cholo, right? Like a pro cholo, right? And obviously, we just have to remember the azine part. But that pro cholo is a compadre. He's a compa, right? And he's holding a cup of promethazine, but he's also hasn't had it, so he's kind of fiending for it, which is that phenogran. He's like kind of losing his mind, and he does look a little interesting. Take a look at the grid; you'll maybe get a good laugh. It's all in the way for us to remember it. It helped me. It could help you, hopefully. For corticosteroid, beyond antiemetic drugs, additional drugs that could happen to have an effect on removing the vomiting would be corticosteroids, benzodiazepines, and cannabinoids, right? So it makes sense because look, we can kind of see also vomiting as sort of like a defense mechanism by the body, right? Like it feels something's wrong, so it pukes it out. Corticosteroids are getting rid of our immune system function, right? Like they at high dosages, like very high dosages, you can basically shut off the immune system, which is good and also bad. Benzodiazepines and cannabinoids, they're downers. Again, those things make the body lower. So you can shut down, or not really shut down, but slow um, the CNS system, and that basically makes messages get slower. Those messages from up here to the abdomen are kind of slowed down, and now you don't really feel like vomiting that much. You know, it's something that could occur. It could come up, right? As for the other, I'm not too sure what that means, so that's beyond me with that. In terms of role of the nurse, right? So if the patient is sedated and they happen to be vomiting, you probably should suction, right? Because you want to reduce the risk of aspiration. That's the whole thing with it. If the patient just happened to be um, vomiting, even though these drugs back here were given. So always be ready to suction, especially if the patient is sedated. Obviously, risk for falls because typically the patients are going to get up and want to go to the restroom to vomit. Um, a lot of these drugs happen to cause drowsiness, which again, we talked about. It's messing with your central nervous system. It's removing messages, it's inhibiting them. The minute you mess with the central nervous system, you can cause things like a little bit of like downing, sedation, not full blown sedation, but like the body's lower. Again, with the cannabinoids, the benzodiazepines, the antidopaminergics, serotonin drugs, those, or the acetylcholine ones. Again, you're slowing. I mean, after all, antihistamines. What's the most well-known antihistamine? It's Benadryl. Um, Diamond. What is it? Freaking. What do you call it again? I forgot. Yeah, yeah. Well, yeah, yeah. But in the end, long story short, they cause drowsiness. So it's a common thing with these. Other than that, reporting like any vomiting and blood. That's something kind of that's well known. And then do not use OTC drugs. Again, you're not supposed to abuse them. Other than that, inducing vomiting, right? Big thing. If it's that necessary, it's just a gastric lavage. Basically, it's like putting down a tube and flushing out the contents in the stomach, and it's just forcing it out. Now, the big thing though is like if you take things that are like caustic chemicals, probably don't want to vomit that out. Or poisons. Now, the poisons part, I'm a little weird on, but poisons, okay, like don't vomit those out because I guess you just don't want to like come back. But the caustic chemicals, right? If you drink something that can burn your lining of the esophagus, right? Now that esophageal lining is kind of like exposed, right? It's lost its protective layer of skin, we can call it, right? So now it's like just straight up blood cells that are just blood vessels that are open. The minute those caustic chemicals come back up, now it could be in your bloodstream. And now you could run a big issue with that. That's why you would probably want to do a gastric lavage instead, because it'll suction everything out or like flush it and everything. And then that's when you can replace it or allow the stomach to go back to full functioning. But the last thing you want to do is just have that cross into the bloodstream. Finishing up here, pancreatitis, right? Big thing in the end. It's just the pain in terms of the anatomy of our body, right? So we have the liver, we have the pancreas, and then we have the small intestine that's like routed from the stomach, right? So here's our liver, here's our pancreas, here's the small intestine. The liver and the pancreas both use the same route to empty exocrine like enzymes into the small intestine when there is inflammation, right, like pancreatitis, that that route that they share is closed off due to the inflammation, kind of like closing or like pushing onto the vessel where those exocrine enzymes are ejected into the small intestine. When that happens, those enzymes are not in the small intestine. Those enzymes are super important because they help us break down that chyme that was made in the stomach and allow us to break them down into the individual like nutrients that we need in order to build things up in our body. So without these pancreatic enzymes, we can't really, we can run into malabsorption issues. We can also like stunt growth and things like that. The big thing with pancreatitis, it's very associated with gallstones in women because they make, like gallstones, a lot of stones made with the with the gallbladder, because again it's pushing on, it's stopping the enzymes from the pancreas to going into the small intestine. And there's a lot to do with alcoholism in men. So gallstones in women, which was read here with women, and alcoholism with men, that's where it comes in. And now I hope you understand a little bit like why is this occurring. It's because there's some kind of inflammation going on that's stopping those enzymes from going into the small intestine. In the end, the only thing you could really do when it comes to treatment of pancreatitis, or at least for like the to prevent malabsorption, is replacement enzymes, right? Supportive drugs will obviously lower pain and gastric secretion and possibly like anti-inflammatory properties, but the most important thing that we should watch out with is the replacement of enzymes for the pancreas. That's where we have our pancrelipase, right? Trade names of Creon, Pancreas, that one's easy, and then Zymase. So what we did was we imagine Zy the pig, right? Zymase, Zy the pig, because funny enough, pancreas, the pancreas drug, this that is pancrelipase, is actually made from pigs. Big thing you want to watch out for is patients with any allergies to those kinds of pig properties, right? But it comes from amylase, it comes from pork origin, right? So lipase, I made these connections with the highlights, right? Lipase will convert lipids into glycerol and fatty acids. Again, you're taking the big and turning it into the small. You're using proteins to turn proteins into peptides, right? And then they eventually turn into amino acids, and then now you could build them up for yourself. Um, Amylase, I did not highlight, but amylase turns starches, basically sugars, into simple sugars like dextrin, and those sugars, again, just starches, your big sugars, into dextrin, little sugars, and then sugars like your monosaccharides. Again, primary use, replacement therapy, because they're having insufficient. It's just a replacement drug, nothing crazy. And thankfully, adverse effects are what every drug seems to have: nausea, vomiting, diarrhea. They could cause high levels of uric acid in the urine. That's something to kind of watch out for. I mean, it kind of makes sense because you're this more. I'm assuming it kind of aims a little bit more with the peptides, right? You're breaking down a lot of proteins. Those proteins could have DNA because again, they're made from pig DNA, like DNA from the pig. Urea is basically byproducts of like like DNA destruction. And then finally, we have the last slide. Oh my goodness, it's been such a endurance event. But long story short, right? Basically, you have to these pancrealipase is basically dosed depending on food, right? If the food is going to be heavy on lipids, it's going to be heavy on proteins or starches, you're probably going to need to give this, right? Lipids are big, especially lipids, because our body has a hard time processing lipids that much. So they might need that supplemental. Another thing too, right? Like you know, biggest thing to watch out for is that there's a urinary amylase, which again comes from the whole pig thing, that helps reduce down starches. But the biggest thing, check for that pork allergy. Just to leave everybody off, we have a grid. I wish that we had more time to go through the entire grid and be a little bit more thorough. I apologize for that. I mean, we're all on on a crunch, and we're dealing with other stuff as well. So we're just trying to, you know, be as helpful as much as we can. Big credit again to Jonathan for all the tech stuff help. Um, Big credit for Victoria and Bernice and Paris for the grids that has been, you know, super helpful. We're going to attach that to this document and then upload it. Um, and then, hopefully we have a good last couple 5 weeks that we have. It's, that finish line is coming up, and I'm tired. I
Yeah.
think everyone's tired. But long story short, also with Ian as well. Big thanks to him and everybody. Everybody's collaborating. I'm really thankful for that, and I hope we could just keep it going. Well, either ways, we'll see you guys later.